Good evening, everyone. Here Imran Abbas. Again, I am live from Dubai, and Professor Faheem, he's a well-known bariatric surgeon from Egypt. It is a great honor for me to interview such a great personality. As viewers, you know, we have started interview series with MGB, OAGB. Then we continue that series after 6 months with safe sleeve gastrectomy. And we had some obsession in January 2022. In February, we have started this interview series of Runway gastric bypass. And we have started this series with great Professor Himpan. And now we will continue this series of Runway gastric bypass every Tuesday, 10 p.m. Dubai time. We will continue till June 2022, and then we will have some obsession. So tonight, really, it is great honor. I know very well Professor Faheem. He's a great role in promoting bariatric surgery. He's a great teacher, and it is a really great honor for me to interview such a prestigious figure. Sir, I will not take your time. Over to you.
It's my pleasure. It's my pleasure to be with you.
Sir, so much thanks. Sir, as you know, we have a repeated question, and I will ask question, and most of our questions are divided in 3 portions: pre-op or patient selection for Runway gastric bypass, then some technical points. So then after post-op Runway gastric bypass. So first, sir, your brief introduction, because people like to know. You're live now on Facebook group Global Laparoscopy.
Yes. Regarding you mean the indication? Is this what you mean?
No, first, sir. Your personal introduction about yourself.
You want me to introduce myself?
Yes, sir, if possible.
Well, my name is Faheem Elbassiony. I'm a professor of surgery at Cairo University. I've started laparoscopic surgery since 1990 and started laparoscopic bariatric surgery in 1998. I started first doing laparoscopic BBG by the time of BBG. I started doing laparoscopic gastric bypass almost 2000. And on 2008, I started doing sleeve gastrectomy. My performance, I tried, of course, one smooth gastric bypass. I tried plication, but in my practice now, I do mainly sleeves and Runway gastric bypass. Sometimes I do one smooth gastric bypass only if the patient is asking for it, or if the patient is too heavy, so that doing Runway will be of high risk. Then sometimes I go for the one smooth gastric bypass.
Sir, excellent. Really, it is great honor. Tonight, I am with someone who has more than 2 decades experience of Runway gastric bypass. Definitely, yes. Tonight we will hear more about Runway, about evolution of technical points and many things. Sir, because we divide our session in 3 groups. So the first we will talk about patient selection. So what is your minimum team and setup for Runway gastric bypass? Because now we are live and many of our surgeons, they are youngsters. Due to this, some question will be very initial, basic question, because also this is a message for those who are going to start Runway gastric bypass. So basic setup and also the team for Runway.
Yes, talking about the indications, which cases, right?
Sir, our setup. So if someone want to go for Runway gastric bypass, they need MDT, they need nutritionist, they need psychiatrist. So if a tertiary hospital.
Yes. Well, first, training the surgeon. I mean, the first he has to be a general surgeon, he has to be a laparoscopic surgeon, and then bariatric surgeon. I mean, he has to do enough practice with the general surgery, with laparoscopic surgery, and then third floor will be for bariatric surgery. Definitely, the Runway gastric bypass needs more experience than the simple sleeve gastrectomy, or even more than the one smooth gastric bypass. But in general, one needs evaluation, preoperative evaluation of the patient regarding whether he deserves, is he indicated for the surgery or not, the weight, how old is he, although we can talk about this, I mean, being too old or too young, there are selected criteria that we can operate below 18 and above 65, but on conditions. I mean, every patient should be taken on his own merits. Even actually for the rest of the patients. So the patient has to have 40 BMI or 35 with a comorbidity, and actually I am a bit classic in my practice. I mean, between 30 and 35 for very selected patients with diabetes that cannot respond to medical treatment. They may, I did few cases for the sake of diabetes. And this is the recommendation of the International Diabetic Federation, actually. It's not mine. Anyway, but most of the patients between 35 and 40, if they are having a comorbidity or above 40. In addition, patients have to be evaluated for psychological problems. This is extremely important because if the patient is not controlled psychologically, or if the patient is receiving antidepressants, for example, or so, they give bad results. Nutritional history has to be evaluated as well, because patients who are emotional eaters, sweet eaters, binge eaters, or grazing, these abnormal patterns of nutrition or eating, they don't usually give excellent results. So the patient has to be evaluated by a nutritionist, has to be evaluated by psychiatrist, not routine, but whenever needed. I mean, in Egypt. And if he is having some other disease, cardiac or pulmonary or whatever, he should be referred to the specialist. And then preparation of the patient or dieting, in most instances, we don't need. But if the patient is having quite a big liver on ultrasound, that's why every patient in my practice, I do ultrasound to evaluate for the size of the liver and the nature of the liver, cirrhotic, steatotic, calcium gallbladder, for example, a gallbladder disease that can be treated or may be treated or should be treated if you are doing gastric bypass. But if the patient is having gallbladder with sleeve, we advise to do the surgery, but it's not 100% necessary, because there is an access to the CBD in case of slipping of a stone. But if the practice will be a gastric bypass, then they should remove the gallbladder if it is diseased, if it is calcular. I don't remove it for routine. This is regarding the gallbladder. And anyway, I do abdominal ultrasound to evaluate the size of the liver and the nature of the liver. If it is too big, and if it is too steatotic, then patient should be advised to keep on diet for a period varies between 2 weeks or 3 months, depending upon the condition of the liver. Because I have seen patients with height 150 centimeter and with a liver of 28 centimeters or 30 even. So these people means that the liver is at the level of the umbilicus. And this means that the operation will be quite difficult. So we need them to stay on a diet. And after doing the diet, the liver varies completely, and the operation is much easier. Also, patients with steatohepatitis, they can be known by elevation of the liver enzymes of the liver functions. I mean, ALT or AST. It means that there is a sort of steatohepatitis. These patients should be taken also with care. Patients with portal hypertension denoted by enlargement of the spleen on the ultrasound, also they should be considered. And if the patients are having some cirrhosis on ultrasound, they should be sent to a hepatologist to evaluate the case of the liver, and if the operation can be carried safely, or he will need some liver support before going to the surgeon. Hypertension should be controlled very well before the surgery. Diabetes should be controlled also very well before the surgery, because this will improve the outcome, especially the hypertension, because patients with hypertension, they can be anesthetized. Yes, the blood pressure, they can be controlled during anesthesia, but post-operatively, the sudden increase in the blood pressure may result in or increase the incidence of post-operative bleeding. Usually, we do not give preoperative anticoagulants, but it's enough to give. To give it post-operatively. I give it routine. I know I'm not jumping to the post-operative management, but preoperatively, usually I don't give, but I give routinely post-operative, even for young patients, for at least 2 weeks. Did I miss something?
No, sir. Excellent. And because this is a great message for our youngsters, another point that I am interested to hear from your side about smokers. What is your protocol for a chain smoker? Are you go for Runway in such a case?
Yes. Well, actually, what I do is that I used to stop them from smoking for 2 weeks before the surgery, but somebody told me, some physician told me that stopping complete abstinence is not something good, but decreasing the smoking is better. But in my understanding, that it's better to stop smoking or quit smoking 2 weeks. Some surgeons, they do not operate on smokers. They consider that these people are a type of addicts, and it's better for an addict not to operate on him, the way as if he is a drug abuser. But this is not what I do, actually. What I do is I used to stop smoking 2 weeks, and after the surgery, I asked them to quit absolutely. But actually, many of them, they go back to smoking.
Yeah, agree. Sir, regarding pre-op endoscopy, this is your routine for all of your patients, and regarding H. pylori eradication?
Yes. Actually, we do not do routine preoperative endoscopy. But I advise rather postoperative follow-up, especially for sleeve, where they are advised every year to go for endoscopy for fear of the reflux, which is almost a routine postoperative. Although many of them, they do not complain, but I used to do gastric volumetry and virtual gastroscopy as a routine after 1.5 months and after 1 year. And believe me, all patients who undergo virtual gastroscopy 1 year after the surgery, after the sleep, they all have some degree of hiatal hernia. They all of them, almost 100%. Some of them, they have reflux and they are unaware, and some of them, they complain and can be controlled by drugs, and very few of them that they have a very silly reflux and they aspirate, and this very small percentage, they have to go for Runway gastric bypass afterwards. But preoperatively, I do if the patient is having a history. If he is complaining of reflux or of epigastric pain or whatever, any gastric complaint or any sign of GERD, we go for upper GI.
Sir, excellent. Sir, so regarding, because now we will talk little about technical points, hope for pre-op, so it was, you have conveyed your message for our youngsters, for patient selection, and for setup for such surgery. So about the role of MDT, everything. So you have highlighted. Sir, now in this session now, we will talk about some technical points. Now you are practicing Runway gastric bypass more than 2 decades. So definitely, so this is the special evolution of Runway and laparoscopic evolution. So is it now about 2 decades? Because in early 90s, there was no one doing Runway with laparoscope. Just they have started 2000 ahead. So can you highlight those technical points so that you have changed in your practice, size of this gastric pouch, size of this gastrojejunostomy, BP? We will also talk about BP limb special. I will have a question for this. For better results, can you highlight that points?
Yes, we started our first gastric bypass by doing a gastric pouch. The gastric pouch that was almost 50 centimeters at the start.
Yeah, 50.
And then it became a bit smaller, and then we ended up by doing something like a micro pouch or something as small as gastrojejunostomy is feasible. But in my understanding that this is not the main issue. Actually, dilatation of the pouch is possible. Of course, if it is quite a small one, the dilatation would not be considered. But do not forget that adaptation happens. Adaptation at the level of the gastric pouch, adaptation at the level of the size of the anastomosis, the gastrojejunostomy, adaptation at the level of the proximal alimentary loop, adaptation, whatever you like. But anyway, this is about the progression of the pouch. We started doing a biliary limb of 30, and then it became 50. Now we do it 100. This is after the introduction of the one anastomosis gastric bypass. We understood that the bile acid pool and the bypass part is more important than the alimentary limb length. So at this moment, we do 100 biliary limb and almost 100 or 100 plus or 100 biliary plus, depending upon the weight of the patient, if he is a primary or a redo case. So this measurement can be manipulated, provided that we have enough common limb. Of course, if we want to elongate the biliary or the alimentary more than the usual, then we have to measure the rest of the small intestine, so that we guarantee that at least there should be 3 meters of common limb, or otherwise we'll have a real nutritional problem. Regarding the size of the gastrogenostomy, we do it now something like 1.2 or 1.5, say 1.5 centimeter. We make it small as to introduce the bougie, but not too much big. Also, it's quite important not to have a big candy cane. If you have a big candy cane, this will represent later on as if it is a new stomach whenever it's dilated, and it will lead also to some cases to reflux post gastric bypass. Gastric bypass is supposed to treat cases of reflux, but sometimes reflux is associated with gastric bypass itself. This is because of the nature of the motility of the intestine. We know that we have 4 types of intestinal motility. The forward, that we all know, and we have a segmental type, and we have a tonic type, and we have a reversal type. This reversal type is the one responsible for cases of retrograde intussusception that we used to see before with cases of gastrogenostomy in the old time, 30, 40 years ago, when we used to do too much gastrogenostomy for peptic ulcer cases. So we used to see gastric intussusception. Why this happens? This happens because there is a retrograde motility of the intestine. It's a part of the body which tries to slow down the flow of the nutrition or the nutrients inside the intestine, so that the absorption will be more. Post-operatively, sometimes in very few cases, that the segment or the alimentary segment has a very potent retrograde motility, and the reflux happens. Also, some cases post-operatively, because of loss of the fat in the hiatus, we have, and the loss of the weight, we have hiatal hernia even post-operative, post-gastric bypass. And I've seen a few cases like that. And whenever the stomach is inside the chest, there is a negative pressure, and there is an instance of reflux after the gastric bypass. What else?
Yeah, sir, excellent, sir. So one question about how many cases of Runway gastric bypass you have performed till this time. Have you any idea, any data?
Actually, no, we don't have that. We operate and we don't count what we, but definitely they are too much.
Yeah.
I don't know how much. I don't know how much, but they are too much.
Sir, definite this figure will be tetra, more than thousands, no doubt, thousands of surgeries. So what is my question? How many cases you have faced this retro movement that you ask? So we have this, and also gastric interception after Runway gastric bypass. Runway, not only in Billroth 1 or 2. I also remember when I was resident and early stages of surgery, we also did a lot of cases, because at that time there was no PPI, and the routine, this was a routine surgery due to this peptic ulcer. So now we are talking about Runway. Have you faced any gastric interception?
No, they are extremely few. But if you have to explain. I mean, you have to know how did it happen. Even if it is one case, you have to know why did it happen. So this is the explanation, but they are not common. They are not common, truly. They are extremely rare, but they happen. And I've got one case of jejunal interception, but I reverse it. It's not a forward interception, it's a retrograde interception. Jejunal.
Yeah, that may be. Yeah. Sir, another
Yes.
thing. So because now you have highlighted 3-4 points, now your pouch size is not micro. That is a standard gastric pouch, and size of gastrojejunostomy is smaller, about 1.5 centimeter, and the BP limb in initial is 100. This standard. So how long time you are following? How many years now you have standardized this technique?
Almost 2 years.
Almost 2 years. So regarding BP limb, that is you know better than me. So this is the hot topic, not only in Runway, all type of hypoabsorptive surgeries. The hot topic is BP limb, and still we cannot standardize still in OAGB or Runway. So have you any standard for BP limb? So just imagine age and BMI of the patient or comorbidities or no. Any type of patient, if BMI is 40, BMI is 60, age is 65, age is 40, age is 45, your BP limb is 100 or no. There is some standard you have changed. Initial surgery, we are talking, not redo, initial.
Yes. Actually, there is nothing called initial or standard for bariatric surgery, because we usually measure length, distances, sizes, but we know nothing about the function. And the outcome is usually the summation of the measurements by the function. The function, nobody knows. The adaptation, nobody knows about it. And they are, I mean, genetically determined. They are, I mean, every patient has his own code in this. So what we do what we think that's correct. I mean, meaning that if the patient is doing a redo, you elongate all the dimensions. I mean, the biliary and the alimentary. But eventually, these patients, they don't give good result as the primary, because there is adaptation, and adaptation can happen after the honeymoon. Honeymoon, yes, everybody loses weight, but the story of adaptation, which is individual, totally individual, happens to the patient. And that's why many of these patients, they need, after 3, 4, 5, 10 years, they need another step of surgery.
Yeah.
So I don't think there should be something called standardization. Every patient should be taken on his own merit according to the experience of the surgeon and the minding of the surgeon. But there is nothing called something solid to be done for every patient.
Yeah.
You cannot do that, because sometimes you measure the small intestine of the patient. I measured some patients. It's around 10 meters, and one patient I measured, it's 3.5 meters.
Yeah.
So every patient is different. Every patient has different motility. Every patient has different psychiatry, psychology. Every patient has different circumstances. I mean, different life. So you cannot. Every patient should be taken by himself, actually.
Yeah. Sir, regarding gastrojejunostomy, are you use any stapler, linear stapler, or no? Your gastrojejunostomy, because size is 1.5 centimeter. Your size of your gastrojejunostomy is 1.5 centimeter, or you do hand sewn? What's your preference?
I use 3 centimeter stapler, a reload of 3 centimeter, and I'm a bit different. I do 2 layers.
Okay.
In my anastomosis, every anastomosis I do 2 layers. The only anastomosis that I used to do 1 layer is the ureteric anastomosis, because I worked some time with the urologist. So only the ureter that I did it 1 layer. Otherwise, all the GIT I do 2 layers.
2 layers.
And yes, and I test it by the bougie.
Yeah.
And I can see it myself.
Yeah, definitely. Sir, regarding, because your size of this gastrojejunostomy is a little, so if we compare with other persons or surgeon, so definite your size of this gastrojejunostomy is smaller than routine, or smaller than so most of the bariatric surgeons. Have you faced any stricture after this Runway?
I saw Kelvin Hager, and I one time I worked with him. Kelvin Hager is used to do a very long lesser curve pouch, relatively long, and Kelvin Hager, he opens. I mean, he does the gastrostomy manual.
Yeah.
And the gastrostomy is quite small, not more than 1 centimeter. And Kelvin Hager is somebody. I mean, he is very experienced, very well known in the field of gastric bypass. So I got that from him. I do the small gastrostomy, number 1. Number 2, before the start of gastrostomy, I used to take the small intestine and lift them up before cutting the stomach. Take the small intestine up and see if they can reach the place of the cutting of the pouch or not. Because I take the whole small intestine and I don't cut the intestine first. I take the whole loop, do the gastrostomy, and then separate the biliary from the alimentary limb at the end. So what I start by taking this loop up and see up till which part it will reach. And this will help me to design the length of the gastric pouch, sorry. If the intestine cannot be reached too much up, I elongate the gastric pouch so that the gastrostomy is done without tension. Because otherwise, it may not reach up. Or if it reaches up, it will be under severe tension and it may leak. Of course, the other alternative is to cut the intestine first and then take them up or take them behind the stomach or behind the colon, just to make the distance short, or to cut the omentum. All these things are to facilitate the gastrostomy, because sometimes the mesentery is very loaded and it's very heavy, and it's really very difficult to take the intestine up, especially in super obese males. So all these are tricks to facilitate doing the gastrostomy without tension.
Sir, you have mentioned a technique of Professor Kelvin Higa, and
Yes.
he also follow retrocolic access. Have you any experience of retrocolic?
No, I don't. I didn't do it, and I didn't have to do it because I elongate as much as possible. And sometimes, in few cases, I did one anastomosis gastric bypass because of this, because I needed a very long gastric pouch just to meet the small intestine. So in this case, I routinely, or sometimes, or many cases, I divide the omentum, but I didn't have to pass behind the colon, or maybe once in my whole practice. But usually I don't do that. I don't pass it behind the stomach. I don't pass it behind the colon. But I divide the omentum, and I will engage the gastric pouch as much as it can reach the small intestine.
Sir, now you have experience of more than 2 decades of Runway gastric bypass. As earlier you had mentioned, when you have started this Runway gastric bypass, at that time your pouch size was bigger than smaller to micro. Again, so now little long but narrow. So what is the question?
No, it's not routine. No, brother. It's not routine. I do it only if I cannot take the intestine up.
No, my question.
But if
my question regarding this, regarding same, because you have changed. So overall, okay, not routine, but you have changed because you also face the pouch when pouch was little larger size than micro, then you standardized. So what was the difference? So when this was, what is my question regarding marginal ulcer? Because one of the concern after Runway gastric bypass is marginal ulcer. When the size of pouch is little, so larger size, then there will be more production of acid, and then there will be more chance of peptic ulcer. When we compare with the one anastomosis gastric bypass, the size of pouch is bigger, but due to buffering effect of bile, there is less chance of peptic ulcer, that is acid-based peptic ulcer after one anastomosis gastric bypass. So I am interested to hear from your side, when it was micro, when it was large size, and now little longer, have any difference between marginal ulcer or no, same?
No, and also in my practice, I didn't have too much peptic ulcers. I have seen it maybe 3-4 times, and in these 4 times, they responded very well to medical treatment. So I didn't have to go into surgery because of resistant peptic ulcer resistant to treat. I didn't have this, but theoretically speaking, yes, if the much you leave of the stomach, you expect more acid to be produced. That's natural. But also proton pump drugs are inhibitors are for that. I mean, if the patient is having, I give routine for every patient 2-month PPI, even for sleep, even for gastric bypass. And I ask patients to chew properly, and if they have anything regarding the epigastric pain or upper GI symptoms, I advise upper GI endoscopy. And I told you, maybe in 3 or 4 cases, I met a peptic ulcer that was treated medically, and I didn't have to go into surgery afterwards. But more importantly, if the acid is big and the patient is having some sort of reflux, then he will have osteophysitis.
Yeah. Sir, regarding this, because we have now technical questions, so we have main 2 concerns after Runway gastric bypass routinely. So this is one is marginal ulcer, another is internal hernia. Are you close always these defects, Peterson or JJ defect routinely? You close, and close which technique you prefer?
Yes, actually, I started by not closing the Peterson space, and then I've got 1 internal hernia. After that, as a routine, I close the Peterson and I close the space behind the jejunalostomy. So these 2 spaces, routinely, I close them with a non-absorbable suture. Routine for every case. And also, I've got an internal hernia after 1 anastomosis gastric bypass. 1 case.
Yeah.
Yes, but I'm not closing this space in one gastric bypass because the incidence is much less than in Runway gastric bypass. But
Sir,
in Runway, I close routine.
So how long time now you're closing these defects after Runway gastric bypass? Now how long time you're closing?
Maybe 4 years or so.
4 years you have closing. So during this time, have you faced any internal hernia after Runway gastric bypass?
No, but in sometimes, maybe 2 or 3 times, the patient is having colics, and they go for CT with oral contrast. The CT answer was most of the intestine were on the left side, and this can point to internal hernia. And in 3 times I went inside and I didn't find any hernia. Only the small intestine are collected on the left side, but without internal hernia. But routinely, I mean, in many instances, patients with Runway gastric bypass from time to time, probably because of the way of eating, they don't chew properly or whatever, so they have a bad colic. And this can be interpreted as a probability of internal hernia. And the CT is sometimes deceiving. And the one who read the CT was a very good radiologist, but he found most of the brunt of the small intestine were only on the left side. But when I got inside the abdomen, the intestine were free and there was no internal hernia.
Yeah.
3 times it happened with me.
Excellent. So one of the issue after Runway gastric bypass is chronic colic pain. So these patients complain, their complaint is this. I have discussed also because I have faced this issue in my some patients. So I have discussed with many persons. So what I do, what is the cause? So rule out everything. Just I think nothing. Then someone, Professor Weiner, I have talked with. I can so mention. I have talked with Professor Weiner. So what will be the issue? He asked me. So the most common reason of this colic pain or this vague pain, not colic, vague pain, is gastritis, bile gastritis after Runway gastric bypass. And also he mentioned, also he removed that remnant. Have you faced such a situation, vague pain after Runway and don't respond to anything?
We all faced that. We all had this. The colics, the pains. I remember that I have seen one case of pancreatitis, but this was post-sleeve, not gastric bypass.
Yeah.
Pancreatitis that without explanation. No, I did not touch the pancreas, absolutely, but I got pancreatitis post-operative. This was in the early post-operative, but it was resolved spontaneously. But in gastric bypass, you see so many things that you cannot too much explain. Of course, the diarrhea can be explained and can be treated. The foul smell of the stool can be also yes, can be explained. And I mean the small intestinal bacterial overgrowth. This is something issue that can be treated and can be diagnosed as well. But sometimes patients complain of borborygmi. They hear loudly the intestinal movements if they are sitting in a community or so. They are very much ashamed, or colics sometimes. This is because we are changing the nature. I mean, the small intestine are not accustomed to receive meat or rice or vegetables. They are not to receive raw something. They are used to receive after being digested in the stomach. So we are changing the physiology. I mean, changing the nature of what God created. We are changing that. So expectedly to have some disagreement from our body.
Yeah, sir. One of the things that is the most nowadays is we are talking about metabolic surgery or impact of bariatric surgery for the treatment of diabetes type 2, that we all know that is due to rise of GLP-1 and also impact of GLP-1 on beta cell. So in a patient that is who is not diabetic and you did Runway gastric bypass, sometime we face nidoblastosis in these cases due to high secretion of insulin and the patient become hypoglycemic. Have you faced such intractable nidoblastosis in your practice? Now you're doing more than 2 decades.
Actually, cases of hypoglycemia are there. In fact, this is about the pre-diabetics. In particular, the pre-diabetics who are not diabetics, but they are pre-diabetics. These people are having insulin resistance, and they have what we call acute insulin response. AIAR.
Yeah.
Whenever they have some sugar, the pancreas reacts suddenly because he knows previously that the patient is having resistance to insulin, and he is used to pour a big amount of insulin in response to the sugar or whatever, because he knows very well that the insulin is, there is insulin resistance. So, as you said, that after the gastric bypass, the GLP-1 raises, and it has an incretin function.
Yeah.
It increases the beta cell population, the beta cell function, and it decreases the death of the cells. Yes. So the resistance is reduced, and insulin is secreted in a higher rate, so that patients commonly, not too much common, but there are patients who are having hypoglycemia. I know that, or I heard, or I read that in some cases the patients have to do total pancreatectomy, and some patients may go for that. But in my practice, I didn't have to do that, and I had to send these patients to nutritionists to arrange the way of their eating or nutrition and manage that. But I didn't have to do reversal even in any of them, because reversal is one of the ways also to treat if it is resistant hypoglycemia or refractory hypoglycemia.
Sir, I had one case that was suffering with nidoblastosis, and you can't believe, no response to any medication. Then I have talked with many persons, many surgeons. Then I convert to a sleeve gastrectomy, that case, a wide sleeve. And then, yes, after that, so because now after sleeve, you know better than me, because now that duodenum also involved and food from that side, and those incretins that are anti-insulin also activate with this conversion. And again, so the GLP-1 depress, and that impact of GLP-1 on beta cell, so also that was less, that is routinely less in sleeve gastrectomy. So yes, patient recover, and then there was no need further medication. Sir, another question regarding hiatal hernia. Just imagine a patient pre-op, you have diagnosed a hiatal hernia, the size is 6-7 centimeter. What is your standard? Till which size you will not go for hiatoplasty? And after that, so this is compulsory to do hiatoplasty, then you will go for Runway gastric bypass. What is your standard? Actually,
what is written is that if the hernia is up to 4 centimeters, you no need to repair it. But in our practice, if you just go and see that even the pillars, the eight, I mean Arabic letter eight, is evident, and there is a shape of weakness or hiatal hernia, you go for under repair, because after the surgery, especially if it is even bypass or if it is hernia, I mean sleeve. Imagine that the esophagus and the stomach, they are in one line, and you have interrupted all the natural protectors of migrating of the stomach in the mediastinum. And the pressure is high intra-abdominally, and it is negative intrathoracic. So naturally, this should go up. And if it did not go up, then there is something wrong.
Yeah.
So, and I know it because as I told you, I do routine virtual gastroscopy and volumetry for all patients after one and a half month and after 1 year. And I noticed that almost all cases, they migrate for 4 centimeters, 3 centimeters, or 5 or more. It's not how far the stomach goes. What's important is if the patient is symptomatic, or if the upper GI is showing osteophysitis or signs of reflux, even if the patient is not aware of that. Actually, if it is not known before, and I go to do a bypass or a sleeve, sorry, and I discovered a hiatal hernia, I go for repair, and I usually try to fix either the fundus of the stomach, or even in few cases I fix the esophagus in the pillars of the diaphragm. So in my intention is not to allow the stomach to migrate up, but actually I'm not too much convinced that probably after some time it will migrate up.
Yeah. Okay.
But you have to do it. I mean, you cannot leave it like this. If you see hiatal hernia, you have to repair it.
Thank you. Sir, which percentage of your cases after Runway gastric bypass are suffering with weight regain? So yes, I know in Egypt, so maybe many cases they don't follow, and also there is some issues, patient is far from, they will go, maybe again they will not consult to your center with weight regain. But overall, you have some data. So now more than 20 years you are doing in same center, same university, same hospital. Have you any idea which percentage are suffering with weight regain? And now, what is your preference to do? Because initially, your BP limb was 30. Now your BP limb is 100. Now about 2 year or 4 year, this is standard. Before that, BP limb was shorter. So there is more chance of weight regain. So which percentage are suffering?
Yes, actually, all of them, they regain some weight. The point is the satisfaction of the patient. I mean, some patients, they regain maybe 20 kilos or more, and still they are safe, and still they can survive with that, and they have no problem. And some patients, they started regaining 7 or 10 kilos, and they rush to you, please do me something, for fear of gaining more and more. The redo surgery is not a picnic. We have to understand this, and we have to explain to the patient that redo surgery has greater risk, and the benefits are usually less than the primary. So we have to exhaust all the efforts, and we have to check the behavior of the patient, and we have to refer to the nutritionist, and we may refer to the new medications, the liraglutide and semaglutide and whatever, just to save another unneeded, probably, or a higher risky surgery. But in case that the gain is too much, then we have to go for a redo. Redo it depends upon the cause of redo. I mean, the cause of weight regain. Is it behavioral, or is it a problem of adaptation or change anatomical with the gastric bypass? So if the pouch is becoming dilated and the upper jejunum are dilated or can become big, you can sleeve them. You can add a band, for example. You can elongate the biliary or elongate the alimentary or elongate both of them. These are all steps that you can do. But in general, I think that the outcome of reduce in general are not that very much high. And I think maybe you agree with me.
Yeah, sure, sir. Sure, definite, because redo surgery is not like a primary surgery, and we must always talk with the patient, and then we can achieve that. Sir, another thing, so because now, definitely when you have started this bariatric surgery, at that time you have started with gastroplasty, or many also you did plication, sleeve, gastric bending, everything. So gastric bending, I remember when I have started, I started bariatric little later than you. I started in 2005. At that time, gastric bending was, I remember, the top and then sleeve, and so we'll go ahead. Sir, according to your experience, so what is the main concern of Runway gastric bypass? So what is your experience? So we know now the main concern of gastric bending was erosion, slippage, and now we are removing all of them. So have you been concerned after Runway?
You mean after Runway or
Runway, after Runway?
In my understanding, I think probably the best outcome is for Runway. Although the most commonly performed surgery is, of course, the sleeve, not because it's the best, but because it's probably the simplest and the easiest to be done. But I guess that the best outcome is for the Runway gastric bypass. But of course, if you have to pay the price for that, I mean, a better surgery, yes, but with higher risk compared to the sleeve gastrectomy. Higher rate of complications, probably, yes. Nutritional deficiencies, more, yes. But the outcome in general, with a very good multidisciplinary team, the gastric bypass, the Runway, is a better surgery. I mean, compared with the single anastomosis, although the single anastomosis gastric bypass probably gives more weight loss, but more nutritional deficiency and more reflux, whether biliary gastritis or even gastroesophageal reflux. I mean, types of reflux are, but definitely the incidence is higher, and the incidence of nutritional deficiency is higher. In turn, the weight loss is more in one anastomosis gastric bypass, of course. Maybe Runway gastric bypass comes in between. Yes, more weight loss than the sleeve, less weight loss than the one anastomosis, but nutrition deficiency are better than one anastomosis and more worse than sleeve, but tolerable. I mean, I did not see a patient with liver cell failure after Runway gastric bypass up till now, maybe one. But I have seen too many after one anastomosis Runway gastric bypass.
Sir, one question. This is a personal question. Which percentage of your bariatric surgery belongs to Runway now in 2022, 2021?
Something like 15%.
15. So when you have started at that time, definite Runway was dominant as compared to now. So what was the reason you have decreased Runway gastric bypass?
Actually, it's the patients themselves. When they go to the media and they see the complications of the Runway gastric bypass and the nutritional arrangements after Runway gastric bypass, the idea that they have to stick for life because somebody explained to them that if you do Runway gastric bypass, you have to stick on nutritional supplements for life. But if you go for a sleeve, you don't have to. So this wrong idea, yes, they come with this idea. And if you try to explain, but usually most of patients, they refrain from, they are afraid to do the Runway gastric bypass. So, but some of them, we try to explain that probably the sleeve gastrectomy is not good for you, especially those who complain of too much reflux, for example, or those with uncontrolled diabetes, for example, or sweet eaters or whatever. You tell to them that probably because the outcome of the sleeve depends to a big extent on the behavior of the patient. Whether or while the outcome of the gastric bypass depends on the behavior of the body, of the intestine, rather than of course, both of them depend on both, but it's more the behavior of the patient in case of sleep, and it's more the behavior of the GIT in case of Runway gastric bypass. You try to explain to them, but they like to do the simple sleep gastrectomy.
Sir, excellent. The same thing we are facing in Dubai. What patient asking? So they ask Taghir Masar La.
Yes.
And another interesting thing nowadays, what they ask me, we need that mini, that is the small bypass, mini bypass, unfortunately. And I always ask them, this is not mini, this is more strong than that Taghir Masar. So, sir, so much thanks. And because
I tell them, yes, it is mini, but it is mini for the surgeon, not for the patient.
For the patient. Yes. Absolutely agree, sir. Sir, really, I have learned a lot. So much thanks, sir. And sir, your message for youngsters who are now going to start Runway gastric bypass are interesting to start bariatric surgery.
Actually, one has to work. I mean, many of them, they jump directly to bariatric surgery without going to practice whether general surgery or laparoscopic surgery. No, you have to be a general surgeon first, and then you go for laparoscopy. You do many laparoscopic techniques. You get the hand-eye coordination. You know the suturing very well, the manipulations, how to use the stapler, how to use the needle and the needle holder. And afterwards, when you are fit, you can go for, and when you start, you don't have to start alone. You have to take somebody who is senior, who is more experienced, just to help you and just to guide you. This is the way we all learned surgery.
Yeah.
Probably in my generation, because we started that we were in the frontier. I mean,
front. Yeah, definitely.
Yes, but in general surgery, this is the way we used to learn at the time of open surgery.
Yeah, absolutely agree, sir. So much thanks, and so much thanks, my viewers, till this time, because now I know in India and Asia Pacific late night, and also in Europe now evening time, we have hundreds of viewers online now, and this program and this interview series is live due to your interest and your follow-up. We will follow this series. We will continue this series of Runway. Next week, Tuesday, 10 p.m. Dubai time, we will be with another legend of bariatric surgery. And please, if you have any question from Professor Faheem, you can ask in comments. And if you have any suggestion, any question, please, you can contact directly with me, or you can ask any question in comment section. Sir, so much thanks, and really you are always sportive, and we need your guidance and your support. So much thanks, sir.
Thank you. That has been a nice experience with you. Thank you so
Thank you,
much.
sir. Thank you, sir. Have a nice time, sir.
Thank you, brother.
Excellent.